it's over to Pampa ma'am. Please start the session. Thank you, ma'am.
I thank the Indian Academy of Pain Physiatrists to welcome me to this forum. Very good evening to all of you. I would, this is a very important topic of pelvic pain, which is a very important aspect of management in women's health. So I would invite Dr. Navita to start, and then we can go for the question and answers and discuss this in a greater detail. Welcome, ma'am.
Thank you. Thank you, Pampa. A very good evening to all, and thank you, Debasish, for a kind introduction. And I'm sharing my screen. Am I audible?
Yes,
Yes,
ma'am.
ma'am.
Okay. So, without further ado, I will just start my presentation, and I'll just make it. So, today's topic is pelvic pain, approach and intervention. So, chronic pelvic pain, what is the definition which has been given by European Association of Urogynecologists or Urologists is it's a chronic or a persistent pain perceived in structures which are related to the pelvis of either men or women. It is associated with negative cognitive, behavioral, sexual and emotional consequences, as well as with symptoms suggestive of lower urinary tract, sexual, bowel, pelvic floor, or gynecological dysfunction. It is a continuous or recurrent or cyclical for at least 6 months. So if the pain has to be there for at least 6 months before we term it as chronic pelvic pain. And I always say it's a complex regional pain syndrome of pelvis. Why we'll see in the further slides. So if we come to the prevalence of chronic pelvic pain, especially among women worldwide, it ranges from 6 to 27%. But although it is very challenging in treating the patients with chronic pelvic pain, the important challenge is to identify the pain generator, because if we don't know, if we start giving the analgesics, they will definitely show some improvement. But if we know what kind of analgesia, what kind of intervention we have to do, so we have to identify the pain generator and effectively treat the identified conditions. So if a patient of chronic pelvic pain comes to any of us, how do we go about it? History is the main important aspect in all the pain patients or any patients. And we know what should we ask in the when we ask for the pain, the duration, the character, whether it is the history tells us whether it's a nociceptive pain or a somatic pain or a neuropathic kind of pain. So whether if it is a neuropathic pain, are the positive symptoms seen or negative symptoms seen? We have to ask them, it's burning, stabbing, pricking, gulling. Is there any relation to posture? Sitting, standing, lying down? What are the aggravating and relieving factors? And for objectifying, we have to ask them the severity, what is on the VAS or the numeric rating scale. Patients who are not able to tell, we show them the warm facing scale. Now, this is what is more important, that if we give this chart, then patients sometimes they are not able to say, or the female specifically, they are not able to tell. Female to female is always better, but when the male patients, male doctors are there, they are not able to tell exactly where the pain is. So we can give them this body image and they can mark on that. Even where the radiation is, you can tell them, okay, draw where the pain comes from, anywhere, which part of the body the pain is there. And then they can mark on this, what are the areas of the radiation, whether it is perineal, abdomen, penile, vulval, if there's a rectal involvement, thigh involvement. Important thing is the relationship with the voiding and also dyspareunia. We should not forget about dyspareunia. A detailed history, why I have written it later, because in the first meeting, they will never say that they have some stress. So we should know what are the important aspects of the history. We should have a detailed history of bladder. We should have a detailed history of bowel. We should tell them to maintain a bladder diary or a voiding diary. The bowel, what is is there any constipation? Have they been diagnosed with IBS? So this is an area, not going into the detail of this, because sometimes they have some burning sensation, they have urgency, they have frequency, but there is no urinary tract infection. Gynecological history is also very important. Is it related to any, the periods are regular or irregular? Is there any dysmenorrhea or menorrhagia? Are they sexually active? Because have they been ever diagnosed with endometriosis? Is there dyspareunia? Does the pain increase with coughing and sneezing, standing? Because this helps us to identify the pain generator and also what we are looking at, because it is a huge umbrella term, chronic pelvic pain. It can be due to any of these organic causes, and if we don't have any cause, it is chronic non-specific pelvic pain. Obstetric history is also very important. What was the birth weight? What is whether they had any significant back pain, pelvic pain? Was there an episiotomy, tearing in the episiotomy? Was the delivery of vacuum of, because of this, there can be some nerve involvement and it can lead to neuropathic pain. And this is what I always say, that it can lead to chronic pelvic, complex regional pain syndrome of the pelvis. Lastly, because psychiatric, if I always say that we cannot ask, yes, depression and anxiety, they are the leading questions. Have you ever been hospitalized for psychiatric illness? Any suicidal thoughts? But important thing is victim of abuse, whether it is verbal, sexual, emotional, or physical, or whether they are in abusive relationship. These two questions, definitely we cannot ask them in the first meeting. But when we have some rapport with the patients, then always ask this, always have this in their mind. If you develop the rapport in the first meeting, definitely go and ask these questions. If not, then when they come back to you, when they have some confidence in you, they do ask these questions, because it has been seen that 80% of the chronic pelvic pain, they have some childhood trauma or a sexual abuse, which has to be taken care of. Now, do not forget that when we talk of chronic pelvic pain, this is very important, pelvic floor dysfunction. There's always a dysfunction of pelvic floor, and there's as we say, when we talk about low back pain, we always have to see the foot, because of the biomechanics, the foot, ankle, knee, hip biomechanics is important. So is the biomechanics of the pelvis, hip, spine complex, because if there is anything in the pelvis area, any organic cause, it definitely leads to changes in the pelvis, hip, spine complex, and that causes pelvic floor dysfunction. Some of the patients, they have congenital pelvic floor dysfunction, which they do not know, but they come to know once they have some pain. So we have to keep on asking. The history is here very important. At some point of time when you were a teenager, did you have any pain in your pelvic? Did you have any spasms? Or the first time, the sexually, when they became active, was there any dyspareunia? Is there any history of dyspareunia? So that leads us to vaginismus, or we can think of some pelvic floor dysfunction or the pelvic floor spasm. Coming to the examination, we should always look for myofascial trigger points. We all know as rehab physicians that what are trigger points, but we do not only have to see on the external part, the suprapubic or the thigh area or the back area, the SI joint, the gluteal area, but also we should always do a paravaginal, upper vaginal or a upper rectal examination if they are complaining of pain inside the vagina or if they are complaining of pain in the anal region. It is very important if they are sexually active, and if they are married, then go for paravaginal examination. Look for suprapubic tenderness. Where are these myofascial bands, lower back? Because if there's anything, the pain is there in the vaginal area or the anal area, they take some position to reduce the pain, and that is what causes the myofascial pains outside in the abdominal or suprapubic areas on the thigh and the lower back. It has been seen that myofascial trigger points of the pelvic floor, they can be identified in as many as 85% of the patients suffering with urological or colorectal or gynecological pelvic pain syndrome. We all know what are myofascial trigger points, but those who are recent PGs who have joined junior PGs, it is basically a localized and often extremely painful lumps or nodules within the skeletal muscle or the associated connective tissue, myo and fascial. So active and latent. Active means whenever you press on them, they will produce the same type of pain or a referred pain as they have. Latent, they may be activated. They are not painful, but they may be activated by any physical, emotional, or any associated stressor. We also have to do this test to know whether we are dealing with a musculoskeletal pain or a visceral pain. So what is Carnet's test? We all know that we find out in the abdomen where is the pain. If we press on it, we tell the patients to raise both the legs, and which increases the muscle pressure, the abdominal pressure, and cause the pain. If we press on the the trigger, and if the pain is there, it means it's a musculoskeletal origin. If the pain reduces, then it is of the visceral origin. So this helps us to identify whether we are dealing with a musculoskeletal pain or a visceral pain. Now, what are the clues by the history? Because we know that the area of symptoms or area of the causes of chronic pelvic pain. So if the patient says, I have crampy pain, then we are dealing with some inflammatory bowel disease or irritable bowel syndrome. If the patient has a neuropathic type of pain, hot, burning, electric shock like, then we are dealing with nerve entrapment. If the pain fluctuates with menstrual cycle, then it can be endometriosis or adenomyosis. If the pain fluctuates, is not associated with menstrual cycle, then there can be interstitial cystitis, irritable bowel syndrome, or musculoskeletal etiologies. If the pain is there with urge to void, whenever the bladder fills and the pain is there, but it relieves on passing urine, so we are dealing with bladder pain syndrome or interstitial cystitis or urethral syndrome. Postcoital bleeding, if the patient gives a history of postcoital bleeding, postmenopausal bleeding, postmenopausal onset of pain, prior abdominal. So these are the red flags which suggest of malignancies, unexplained weight loss. Again, the first thing which should come to our mind is malignancy or any systemic illness. Here, we should do an imaging, send the patient to the whether a gynecologist or a urologist. If there's a prior history of abdominal surgery, adhesions should be looked for. So that is how we come to a conclusion with history. And physical examination, if we see any adnexal mass, ovarian neoplasm, if the uterus is enlarged or tender, then it might be adenomyosis or chronic endometriosis. If the mobility, uterine mobility on bimanual examination is not there, again, endometriosis or adhesions. If there's a pain on palpation of outer back, of the back or the pelvis, then the pelvic wall is the source of the pain, or the abdominal wall is the source of the pain. If there's a pelvic floor muscle tenderness, then again, bladder pain syndrome, interstitial cystitis. It can be piriformis or a Levi-Teni syndrome. If there's a point tenderness in vagina, vulva, or bladder, then definitely adhesions, endometriosis, nerve entrapment. If there's a vulvodynia, positive Carnot sign, as we discussed, myofascial or abdominal wall is the source of the pain. Suburethral mass, fullness or tenderness, urethral diverticulum, uretrosacral ligament abnormalities, then it is adenomyosis, endometriosis, malignancy. Vulvar or vestibular pain, it is the vulvodynia. So we have to look for, these are the red flag which are in starry this thing. So we have to, this is a red flag for a serious systemic illness. Now, if we come to the algorithm for evaluation, so if on evaluation of chronic pelvic pain in history and examination, if there are red flags, yes, evaluate for serious systemic disease. So send them to a uro or gynecologist. If no, then you have to find the specific suggestive, what are the findings which are suggestive of specific disorders. If there is if there are some findings which of specific disorders, evaluate and treat for the specific conditions, send to your colleagues, maybe colorectal surgeons or gastroenterologist. If no, then do a basic testing, which includes CBC, ESR, urine analysis, gonorrhea, pelvic ultrasound. If it is normal, refer for laparoscopy if the pain is severe. If abnormal, then again evaluate and treat for the specific conditions. If on laparoscopy, if the pain is severe and the laparoscopy is abnormal, evaluate and treat accordingly. If it is normal, then comes our role, that is meant you treat it as complex regional pain syndrome. So here is where our role comes, I think. So this is how is the algorithm for evaluation of chronic pelvic pain. Now, how do we manage? Now, if the patient comes to us, and how do we manage the patients of chronic pelvic pain? So we know that in the mechanism, I won't be going into the detail, that there is some insult. It can be to any organ. Here we have taken off ICBPS, but there can be insult to the bladder. There can be insult to the the uterus. There can be insult to into the intestine. But that causes a neurogenic inflammation, that causes peripheral sensitization, and if not treated in time, they keep on coming back. It causes central sensitization. So I always say chronic pelvic pain is complex regional pain syndrome of the pelvis. How do we manage it? The aim is to alleviate the pain and improve the quality of life. Now, there are 4 cornerstones of management: the pharmacological and the non-pharmacological. Pharmacological and the non-pharmacological consist of physical therapy, psychological counseling, because the pain is chronic, and the 4th one is the interventional pain management. We all know about it, the WHO step-ladder pattern used for cancer, but it can be used for, it is very commonly used for chronic pains also. So it can be used for chronic pelvic pain, starting with non-opioids like paracetamol or NSAIDs. If it is mild, if it is moderate to severe, go to weaker opioids and opioids. If not, then the intervention, the 4th letter is the interventional pain management, which can be incorporated according to the severity of the pain. So what else? What are the adjuvants which can be used? Because if it is a neuropathic pain, we have to give them some gabapentinoids, tricyclic antidepressants, SNRIs, or a combination of these. Definitely, we have to give them muscle relaxants because there is some component of pelvic floor dysfunction or a spasm of the pelvic floor muscles in the form of tolperisone is very commonly used nowadays, cyclobenzaprine or tizanidine. So this is the guideline of a comparison was done in chronic pelvic pain, comparing the gabapentin versus amitriptyline, and it was found that it has the combination is much better and VAS scale improved, but the quality of evidence is low. Then what agents can be used? Acetaminophen can be used in the somatic type of pain. Gabapentin, pregabalin can be used in neuropathic type of pain. The evidence is again for general neuropathic pain, but limited studies are there on chronic pelvic pain. Gabapentin plus amitriptyline in neuropathic type of pain. There was a small study in chronic pelvic pain which suggests that combination was more effective as compared to amitriptyline alone. If the pain is type is inflammatory, NSAIDs, they have good evidence like dysmenorrhea, but there is the Cochrane review indicates the lack of effectiveness of endometriosis. So in endometriosis, NSAIDs, there is no evidence that it helps in reducing the pain. Opioids can be used in chronic non-malignant, but it is controversial because it has the side effects. They are more as compared to the better effects. So they are controversial for long-term use. The oral contraceptives, the progesterones or the gonadotropin releasing hormones, In cyclic type of pain, they have good evidence, like endometriosis, but non-cyclic pelvic pain, there's not a very good evidence of it. The SSRIs, if the pain along with there is depression, definitely they have good evidence for benefit of depression, but not for pain. TCAs, SNRIs, they are used in neuropathic pain. Again, the evidence is on neuropathic pain, but there are very few studies which are specifically on chronic pelvic pain. Now, coming to the physical therapy, yes, it has some role. Physical modalities can be used in the form of TENS at the tender points and the pelvic floor muscle. And the EUA guideline says that it has a level 1B evidence in improving the pain with grade B recommendation. Myofascial release again has a very good evidence. And if the patient has myofascial pain inside internal, then internal massages can be done, which has evidence of 1A, and it is recommended as grade 1, grade A. Vaginal dilatation can be done. EMG biofeedback again has 1B level of evidence. Now in these, because they have pelvic floor dysfunction or in the form of spasm of the pelvic floor muscles, here the pelvic floor relaxation exercises are used. They should be prescribed rather than Kegels exercises, because the more they do Kegels exercise, the pain increases. So the important thing over here is pelvic floor relaxation exercises should be taught to these patients. When you write your prescription, you can write TENS and pelvic floor relaxation rather than the Kegels exercises. Also, now it affects the psyche, so do not forget to refer to your counseling. Do a CBT is very important, because as in all the chronic pains, cognitive behavioral therapy, it helps in the form of relaxation techniques or psychotherapy, and the evidence is level 1B with recommendation of grade A. Now, again, coming to the this shows that the cognitive behavioral therapy has a very good recommendation for chronic pelvic pain. Now, what are the recommendations? So if you psychological distress is common in pelvic pain, but should be interpreted in the context of pain, grade A recommendation. Whether we should ask the patient what he or she thinks may be wrong to cause the pain, to allow the opportunity to inform and reassure as appropriate, again has level B a recommendation. We should try any psychological interventions in combination with medical and surgical treatment or alone. So they should be tried. All the psychological intervention, it has level of evidence is grade 1B and grade recommendation is grade A. So whatever we are doing, we should always send them for not only for physical therapy, but also psychological interventions in the form of cognitive behavioral therapy. Now, what are the interventions which can be done in these type of patients? When you send, if myofascial release does not help, then we can go ahead and find out the tender points, and we can go ahead and do interventional pain management, that is myofascial release under ultrasound. Now, all of us are using ultrasound guidance, so we can find out the ultrasound, the myofascial band. This is in the suprapubic area, this is the rectus muscle, and we can see this hypoechoic band present in the rectus abdominis muscle. That's the sheath, it is hyperechoic. So we can give injection, we can release this in the sheath as well as the myofascial band. We can inject and release the myofascial trigger point. And this was a study done by Langford et al. And they examined the role of specific Levita and eye trigger point injections in women with chronic pelvic pain. It was, how was it identified? By intravaginal palpations, and they injected with bupivacaine, lidocaine, and triamcinolone. It was found that 72% of the women, they improved with the first trigger point injection, and out of 133% being completely pain-free. So even if you do just a myofascial trigger point injection, the 72% will have a benefit only by one injection, and 33% completely pain-free. So the level of evidence is 1A, recommendation is grade A. So also not only this, the botulinum toxin injection was also tried. So Abbott and colleagues, they did a RCT, and it was a double-blinded RCT. And how did they measured the pelvic pressure on vaginal manometry, and because it is a pelvic pain, because there's a pelvic floor dysfunction and the spasm of the pelvic muscles is too much, so we did a vaginal manometry and gave, out of 60 women, they divided into two groups, one group with botulinum toxin 80 units and one with saline, and followed it up for 2 years. And they found out that the improvement was seen in botulinum toxin injection, where they gave the botulinum toxin injection in the form of decreased subjective pain, pelvic pain, and also decreased pressures on the vaginal manometry. So the spasm of the muscle, pelvic floor muscle, reduced, which was objectively seen by the vaginal manometry. Then there can be in the myofascial bands, the nerve entrapment can be there in the like a pudendal nerve can be entrapped. So here it can be a useful tool when we give a pudendal nerve block in pudendal neuralgia in patients with pelvic floor dysfunction, either as a cause of pelvic floor myalgia or a result of nerve irritation. So we can do a pelvic pudendal nerve block. And we all know how to do pudendal nerve block is by ultrasound guidance. We know it, so we can do a pudendal nerve if there are signs and symptoms of pudendal neuralgia. Now, if there is when we talk of CRPS, we have to talk of sympathetic plexus block, in which the superior hypogastric plexus, it supplies, is the sympathetic nervous system which supplies the most of the pelvic areas. So if you block this structure, one can relieve the pain. Theoretically, one can relieve the pain in the visceral and the pelvic regions from multiple etiologies like cancer pain, PID, endometriosis, interstitial cystitis, myofascial pain, vulvitis, cystitis, and the array of even irritable bowel syndrome, pain due to adhesions. So if you see that in the history and in your examination, the myofascial bands, they have been taken care of, but still the neuropathic pain is there, then we can go ahead for superior hypogastric plexus block. We all know how to do it with ultrasound guidance at the level of the umbilicus. We find out the fifth lumbar vertebrae where the iliac vessels, they divide into left and the right common iliac. We inject at that point because that is where we know is the superior hypogastric plexus. And that's the needle coming in, and we're doing a superior hypogastric plexus block. Now, what is the role of ganglion of impar block? This was a study done by Milweska et al. and from Poland, and they found out that they did a comparison, or they did ganglion impar block, a neurolysis in chronic pelvic pain due to malignancy and non-malignant region. And they found out that the relief was varied from 4 weeks to 3 years. And in some cases, like in 4 cases, there was a complete and permanent cessation of the pain was achieved, and there were no complications they were seen. So we can go ahead and do a ganglion of impar block or a neurolysis in the form of whether you can do a RF ablation or phenol block for chronic pelvic pain. Neuromodulation, when we do complete sacral neuromodulation, it has been seen to be safe and efficacious option in that if other treatments fail. So in the refractory patients, and the success rate was seen in 72% at a median follow-up of at 61 months. Now is the era of peripheral nerve stimulation, where we can keep the lead on the pudendal nerve and we can stimulate from outside, and it can be done ultrasound guided. And this was a study done especially in ICBPS, where 84 patients, they were given pudendal nerve neurostimulator of the indication was mainly the pelvic pain, and they followed up for 12 months and found out that it has a very good relief in the pain in these patients. And if we don't want to go very non-invasive, then we can do tibial nerve stimulation. And this was a study done by Nidhi et al. And they found out that there was significant improvement in the pain scores in the TENS therapy on the tibial nerve when they stimulated the tibial nerve at the level of median malleolus. Now, coming to what are the guidelines for medications and interventions? and what is the level of evidence. So paracetamol can be given in somatic pain. Level of evidence is 1A. Recommendation is A. Grade A. NSAIDs, if there's an inflammatory process like dysmenorrhea, pelvic pain with dysmenorrhea, we should go ahead and give NSAIDs. If there's a neuropathic pain, then antidepressants along with TCAs, duloxetine and venlafaxine. Level of evidence is 1A. With grade A evidence, it is very effective, but no specific evidence for chronic pelvic pain. The anticonvulsants and the gabapentinoids, again in neuropathic pain and fibromyalgia, they are very effective in the treatment. Gabapentin in women with CPP, the level of evidence is 2B and recommendation is B. Topical capsaicin, again the level of evidence is 1A and recommendation is A. Opioids in chronic non-malignant pain is beneficial in small number of patients, so they can be used with grade A recommendation. Nerve blocks, level of evidence is 3 and the recommendation is C. They have a role, but it is a part of the clot management plan. TENS again is very good. There is no good evidence for the data against TENS, so it can be used in chronic pelvic pain. And coming to neuromodulation, yes, it is again the level of recommendation is grade C. But we need more research and more data in neuromodulation as well as nerve loss. So coming to yes. So what is the algorithm of pain management? If we come to the algorithm of pain management, so if the pain is described in neuropathic or central pain syndrome, central pain terms, if it is yes, then the first line of management would be amitriptyline, gabapentin, or combination, or alternatives can be the active part, the pregabalin or the nortriptyline. Send them, review again after a few weeks. If there is an adequate analgesia, review regularly and consider dose reduction. If there is inadequate response, consider adding another first-line agent and rotate the agents. If the patient is still in pain, then refer to pain specialist. If the pain is not neuropathic or central pain terms, use simple analgesics. Review after 2 to 3 or 4 weeks. If there is adequate analgesia, discharge back, inadequate response, then refer to pain specialist management. This is the algorithm of management of chronic pelvic pain. And these were the guidelines as I am the founder member in Bladder Pain Syndrome Society, Gibbs Society of India. So we found we have given some clinical guidelines for the management of ICBPS, which can be seen on the Gibbs GIBS Gibbs the website of the Gibbs investigations. So if we come to the algorithm of the management or how do you go about the chronic pelvic pain, this is what I have made that if the patient comes to us, then assessment, assurance and education is very important because any chronic pain, not only chronic pelvic pain now, these patients, they keep on searching for some diagnosis and the pain management that when they come to us or whenever they come to you, they must have seen more than 10 doctors and more than 10 gynecologists or urologists, but they have not been diagnosed of chronic pelvic pain. They have been diagnosed of ICBPS, but they have been diagnosed of endometriosis, which is now very common, but chronic pelvic pain, they are not being, even after being operated for endometriosis, they come back with the same pain what they had before being operated for endometriosis. So that is why, how do we go about it? The step 1 is history, physical examination. And when they have some bladder history, like ICBPS, then dietary history is important. IBS, again, dietary history is important. Stress plays an important role in all kinds of chronic pelvic pain. Look for myofascial bands. Reassure the patient that yes, it will take time. It's not that one time you come to me and there will be some magic and then pain will go away. So education is very important. Step 2, when they come back to you, start NSAIDs like the step 1 of the WHO step ladder. If the pain is, depending on the pain intensity, you can start weaker opioids. If the pain is moderate to severe, like tramadol or tapentadol, even once they are not naive, opioid naive, then you can use buprenorphine also according to pain score. You can add, if there is a neuropathic component, add gabapentin, gabapentinoids or amitriptyline. Combination always works better. Start physical therapy and also talk to them once they have your confidence. Start cognitive behavioral therapy, which will be always in the second or the third visit, because they are always reluctant to go to a counselor. But reassure and educate the patient at each and every step. If the patient doesn't get better, if they come back to us, use stronger opioids. And if you don't want to use the stronger opioids, start interventional pain management in the form of myofascial release under ultrasound guidance. Continue or add your cocktail of neuropathic pain, continue physical therapy, cognitive behavioral therapy, or psychotherapy. Now, if they come back, what would be the step 4? If you see that there is some entrapment, pudendal nerve entrapment, go for pudendal nerve block, increase the dose of the weaker or the stronger opioids, increase the dose to the maximum dose of your gabapentinoids or combination, continue with physical therapy, cognitive behavioral therapy. Reassurance, education at each step is very important. If you find they come back, the step 5 is if you can go for ganglion impar or superior hypogastric block if it's a neuropathic or a CRPS type of picture. Increase the doses, continue physical and cognitive behavioral therapy. And you can also, in the next step, you can start using peripheral transcutaneous tibial nerve stimulation, which is available to every one of us, and continue with the other steps. Reassurance, reassessment, because every time they might come with newer, they come back, assess, reassess, reassure, re-educate. That is the mainstay, because sometimes the myofascial release, if you have done myofascial release of some bands, they will get better, but the other bands will unmask. You have to tell them about the posture, about the right posture, how much to sit. This is very important. And that these are small things, lifestyle changes, dietary modification. These subtle small things, they do help in a greater benefit of the patient's outcome. So it's basically a teamwork, and we all of us, we work for the patient's outcome. As a rehab physician, we know the importance of a multidisciplinary and a multimodal approach. So to summarize, it's very challenging to treat chronic pelvic pain. We have to use multidisciplinary and a multimodal approach. Not one approach works at one time. Role of trigger point injections is established. Definitely go ahead and do a trigger point injection, but still we need to know a lot about the potential of hypogastric pudendal nerve block. Peripheral nerve stimulation also has a good potential or percutaneous tibial nerve stimulation. It works as a neuromodulation, so it has a potential role. Study should be done, and all of these can help in improving the quality of life, because it's a privilege to treat pain, for sure. And we work for a smiling face and freedom from pain. Thank you so much.
Thank you, ma'am. It's a great presentation from you. We have covered extensively about this pelvic pain, starting from the origin, the management line, the interventions, so beautifully. So I would ask the members present to ask anything that you want to know. From the chat box, I will focus on one question. Ma'am, ilioinguinal or genitofemoral nerve block have any role in chronic pelvic pain?
If the cause of the pain is, that's important, that the pain generator we need to know the pain generator. Ilioinguinal and iliohypogastric, they have a very specific area. So if there's a pain along the groin and along the medial side of the thigh, and it is a neuropathic, do a diagnostic block and see if it is helpful or not. Usually it's not so. If there's an entrapment, if there's a myofascial band which is causing an entrapment of this nerve, go ahead and do this, just like the pudendal nerve.
Okay, ma'am. Any more questions coming from the floor?
I will request Pampa ma'am to please share your experience in pelvic pain management and rehabilitation. Please, ma'am.
Yes. Look, I have always worked in the grassroots level without interventional scope. So I will definitely say that this topic is very important. And when I met patients with antenatal and postnatal rehab, when I was doing that in my Sagar Datta Medical College where I was working last. So there, this population of pelvic pain, when they came to me, this pelvic floor dysfunction is a cause of this pelvic pain. So this pelvic floor dysfunction, as madam has rightly said, so many causes. Okay, the prolapse of any visceral organ that may cause the pain, the pelvic floor weakness. Okay, that hypertonus and pain caused by any unhealed lacerations or trauma per se to the sacroiliac joints during delivery, or any osteoarthritis developing this degenerative pain and the like, and other causes like chronic cough, obesity, constipation. Ma'am has gone for so many extensive causes in the visceral and the other areas of pain where you have to look for. So this pelvic pain, okay. Now the pain, most importantly, where the patients I found was a pelvic girdle pain. This pelvic girdle pain was confined to an area between the PSIs and the gluteal folds. Okay, so there the pain, this pain will be focused on this part of either the sacroiliac joints or the pubic symphysis and the sacroiliac joints, the posterior suprailiac spine. And there are 5 categories of this pain. Okay, the 5 subgroups. The first is a symphysiolysis, which is the condition where that trauma due to this symphysis pubis separation will cause that pain. Next is the one-sided sacroiliac joint pain. Then the double-sided sacroiliac joint pain. I typically found these patients. And then the pelvic girdle syndrome, where these 3 commonly coexist, and the miscellaneous group. Okay. So there was this pelvic girdle pain clinically. If you go for clinical tests, then the active SLR is a differentiating test from 2 types of the PGP, which is a specific and a non-specific PGP. Okay, the specific PGP is where the SLR is positive. The patient is asked to lift the leg 20 cm from the floor in the supine position. And then this pain in these areas will indicate a non-specific PGP, which is due to the loose sacroiliac or this symphysis joint, which is not, which is traumatized. Okay, there is a looseness of that joint. So then the non-specific PGP is where this SLR is not positive, it is negative. The patient can lift the leg. So this differentiation of this type of pain, and I had to focus not on intervention because that was not my scope. I had to focus on the exercise therapy more. So I went with this type of exercise therapy where I gave this type of specific PGP where there is a looseness in this muscles, pelvic floor muscles, that has to be strengthened. Strengthening of the this four muscles cause the abdominal canister. Okay, one is above is the diaphragm, below is the pelvic floor, in the posteriorly is the multifidus, and in the anterior is the transverse abdominis. So strengthening of all these and the pelvic floor muscles, and in the other group, non-specific PGP, where you have to relax the muscles. It is already overstressed. So we have to go for relaxation of these muscles. And this muscle, madam has nicely said, the pelvic floor relaxation techniques, where I used to use the Jacobson's relaxation techniques and other methods of deep breathing and relaxing your muscles. So this really gave me results of this pain management. And the drugs, madam has nicely said the drug role. When the patient is pregnant, you have no option other than paracetamol. With the patient non-pregnant, you have a lot of options. And intervention is always in your hands. So this much I can tell from my experience. If you want to know more, then ask me if I can help you. Let me see from the chat box. And no more presentation, no more questions, ma'am. So, madam, please.
So there are some questions I can see, Pampa. So there is someone has asked about any specific exercises after superior hypogastric block. Yes, the exercises remain the same, pelvic floor relaxation, and we have to see where exactly what are the tight muscles. Sometimes the TFL, the adductors, they are tight. Sometimes the glutes are tight. So this has been seen, if we release these muscles, then the pelvic floor relaxes on its own. So after this, whatever you do, the exercises will be the same. And if they have some back pain, then you can add some exercises for the back also. Then piriformis syndrome means, is it a question, sir, or a comment? I cannot understand that. What are the common causes of chronic pelvic syndrome in SCI patient? So in SCI, again, the bowel and bladder has to be looked for. So there is a constipation, there is a bowel neurogenic bladder, there is a neurogenic bowel. So that can be the cause of chronic pelvic pain. And it doesn't mean that whatever causes we are talking of, like fibromyalgia, the IBS, ICPPS, they can also be present concurrently with SCI, but which is very, very less. But we should not forget that there can be endometriosis in patients of SCI. So there can be the causes which are gynecological or urological or GI. So that has to, and GI is more common. They are constipated. They have a neurogenic bowel. They have a neurogenic bladder that can lead to chronic pelvic pain syndrome in patients of SCI. Yes, definitely, Dr. Suraj. I'm sorry, Pampa. I have read the questions while you were.
Okay, madam. Please go on.
That's why. Yes, I'm so sorry. Everyone, I think so, are wanting to watch the match. So, yes, the last one is that whether, yes, we can definitely, we had few patients and then we tried myofascial block and the transcutaneous tibial nerve stimulation. Definitely we can, the neuromodulation was there. That's why I've written in the last step, but no, we can use it as a third step also. Once when we do a myofascial release, if we send to the physical therapist, we can start doing the tibial nerve, transcutaneous tibial nerve stimulation earlier also. Yes, very nicely pointed out. Any other questions?
I think, ma'am, there is no more questions.
Score is 97.3. Everyone has to go, I think. So thank you so much for being there and at this important crucial time. Thank you, Debasish. Thank you, Indian Academy of Pain.
Actually, ma'am, last time the participants were almost around 100. But this time because of match, it was
I
low.
was thinking that the same thing because the class and the starting of our talk and the class was at the match was at the same time. So, but definitely people have come. So, thank you.
Thank you, madam.
Thank you,
Okay.
Pampa.